So I guess I shouldn't. What the heck? Most respiratory departments are centralized in the sense that you have a manager or director, and then from there are perhaps a shift supervisor in some of the larger institutions, and there might be team leaders in various areas of the hospital, but there's always a chain of command that is there that you need to be aware of. We were talking earlier about patient focus model, and it was a model that basically decentralized everything, and there was not a need for a specific department. Tasks were done by a very limited number of people. So the same person that fed you, changed your bedpan, gave you medication, draw blood, was all done by one person. And it seems like a nice idea. Patient doesn't have to come in contact with 40 different people, but it's totally impractical from a operational standpoint. And it kind of went away in the long run. Every department or every hospital has a vision statement or a mission statement that basically says what their purpose is. That is something that, in theory at least, you can always turn to say that's who we are. That mission statement then drives what goals and objectives the board of directors of a hospital or a healthcare agency does, and then it's broken down into operational tactics in the process. You guys all heard of Keystone? I think it's still around, but it basically was a group. It was a group of hospitals that wanted to establish benchmarks for quality control. So things like the nosocomial infection bundle, keeping the head of the bed up 30 degrees, using supraglottic suction on the end of the tracheal tubes. All of those things derive from the Keystone. But there's always a goal to try and improve the care that we end up doing. I love this. Have you guys ever heard of a paradigm? What paradigm means? Paradigm is just a way of viewing things, a way of looking at medicine or looking at whatever. So, a group of scientists has 5 monkeys in a cage, and in the middle is a ladder, and on the top of the ladder there's bananas. Okay. Every time a monkey goes up the ladder, the scientist soaks the rest of the monkeys with cold water. After a while, every time a monkey goes up the ladder, the other ones beat him up. They don't want to get drenched. Sometimes no monkey dares go up the ladder regardless of the temptation to do so. Then they decided to go ahead and substitute one of the monkeys, and the first thing the new monkey did is he went up to the ladder to get the banana. And the other monkeys beat him up. After several beatings, the new member learned not to climb the ladder, even though he had no idea why. Second monkey was substituted, the same thing happened. Third one, fourth one, until they all were finally replaced. What was left was a group of 5 monkeys that, even though they never received a cold shower, continued to beat up any monkey who went up the ladder. You ever had that situation where you go into a department, well, why do you do it this way? Well, that's the way we've always done it. No one understands. That's a paradigm shift. And to change that is obviously a very difficult thing for any manager to do, because you'll see this especially when you have a new manager come into the department who was not from within that department. All of a sudden they, why are you doing it this way? Well, it's the way we've always done it, even though there might be a better way to end up doing it. So that's how things are done around here. Only 2 things are infinite: the universe and human stupidity. I'm not so sure about the first one. Yeah. All right, protocols. There is nothing so useless as doing efficiently that which should not be done at all. And that really is the whole reason behind looking at protocols, trying to standardize stuff. When I was a manager at Bon Secours, we had JCHO come in, and they were talking about protocols, and one of the physicians was commenting about how was kind of looking down at cookbook medicine. You know, how you're following a list to do things, and it's like, well, if you're not using the cookbook, what are you doing? You have to have some kind of guidance to be able to get healthcare administered in the process. The protocols were one of us finally there. Are you guys aware of the difference between a capital budget and an operating budget? Assume not. Okay. Have you ever worked in a hospital where you haven't had well, those of you who have worked in a hospital, let me direct this towards you, where you haven't had a raise in 5 years, but they're building a brand new ER. It's going. Where's the logic here? They're two totally different budgets. Capital budgets are what we establish to do long-term large projects, like building a new ER, like buying a fleet of ventilators. Okay. Operating budget is what is going on day to day. Operating budgets are established, and I will be perfectly honest, as a manager, 85% of my operating budget was personnel. That's the biggest piece of that. So if I got to cut my budget without cutting any bodies, it's very, very difficult. There's only so much you can scrimp on, nebulizers, handheld nebulizers, before that finally gives out. Capital budget's a little bit different. Capital budget, the funding for that is actually through bonds being floated. So every month they turn over another $60,000, $80,000, $150, whatever $1,000 in bonds that are being issued, and then they pay them off the following months as they go along. So it's a totally different source of revenue that you end up having. Most of the inpatient, virtually all the inpatient and outpatient now, are all based upon a prospective payment system. Okay, so good morning. When you go into the hospital, well, first of all, let me back up. The vast majority of income is paid through either the government, the federal government, in the form of Medicare, the state government in the form of Medicaid, or through private pay insurance, most of which follow the Medicare process. So, for instance, Blue Cross Blue Shield is the intermediary for Medicare in Michigan. So the federal government basically pays Blue Cross and Blue Shield to administer the payment to the hospital, and they use exactly the same thing that Medicare's guidelines use, which are called diagnosis-related groups, DRGs, which you may or may not have, Jeannie covered that or not. When a patient with COPD comes in, there's a specific amount of money that the hospital gets for that admission. How the hospital spends that money, they don't care. If you want to do 47,000 chest x-rays, go right ahead. But we're only paying you this flat fee. Unless there's some underlying outlier reason, they're going to get paid that flat fee. If they can get that patient admitted and treated and discharged for less than the amount of money that they get, they make a profit. If they spend more, they get a loss. So the whole premise of having a charge, so for instance, a breathing treatment, there's a charge for that breathing treatment. The only people that really pay that would be the patients who are private pay, who pay out of pocket. Does that make sense? There really is not such a thing as a charge. As a department, prior to DRG, we were revenue generators. The more treatments you did, it was a fee for service, so we got paid more. Once DRGs went in, we were an expense center, and all of a sudden, we weren't as good. We were basically taking money from that fixed amount of money that was given for that diagnosis. So talk about a paradigm shift. It was huge. And some hospitals learned the hard way that You can't continue to have a huge cost because it's going to catch up with you eventually.
And why do they still order treatments for pretty much every single person?
I mean, that's why protocol should be in place. I was talking to a grad. She sent me an email. Had a patient came in, 25 years old, hip surgery or knee surgery. They wanted them to do non-smoker, perfect health. Wanted to do breathing treatments on him with albuterol. Totally not indicated. And that's where you need to have. And again, it's you're fighting against a group of physicians, and the only people who's going to win that battle is another group of physicians. So you have to have a strong medical director who's going to say, no, this is nonsense.
Because you'll discontinue them.
And they'll just order them again.
And a couple hours later, you'll go back and the order is back on.
Yep. This is the problem with healthcare.
But
Yeah.
in that situation, though, if it's not indicated at all, and you discontinue the order and they reorder it again, I mean, that's when you can have like a private conversation with that physician and say, I'm not doing this because it's not.
The question should always start out with, what do you want done? What is the purpose for this? If you look at physical therapists, the physician does not write physical therapy to do this task this many times per day. They say consult physical therapy. They're going to know what to end up doing. Really, that's what should be done in our ballpark also, but it's not. Term FTE, you've heard of that? Full-time equivalent. So every department are budgeted for so many FTEs. That could be a full-time person, somebody who works 40 hours a week, or it could be 2 part-time people that add up to that. Every classification of job has a specific description of duties that they're able to perform. You should have an idea of that one. And hiring is extremely important because there's a huge cost associated with it. Not only do you have to pay that person to be trained for that position, somebody else is basically having a less productive day because they're training you. So there's a huge cost that is there. And in a given day, the work that you do, there's time spent where you're not doing something that's directly related to patient care. You've got to walk to the next patient room. You got to go to the bathroom. You have to go to lunch. Those are all non-productive things that are there. Most of the cost of labor is the wage that is there in benefits. Mr. Coffee, I definitely agree with that one. Shut up. We'll talk a little bit about hiring when we talk about that process. Yeah. I'm going to skip through some of these. This is just different ways to resolve conflict. This is where we really should start. When you have a conflict with another employee, this is where I ended up getting in as a manager. When 2 people had a problem with each other in some fashion, I never liked being the person that had to arbitrate it or mediate it. You have to be more proper term. Or work it out amongst yourselves, because if we're going to leave it up to me, nobody's going to end up being happy in the process. And hopefully you never get to this last step where you're suing somebody. But there's different ways to end up doing this. And if you go to this website, that's where I got all this stuff from. I'm going to skip through it. All right, so what do employers want? Well, there are certain things, certain core parts what we call core competencies that are things that make an employee more desirable, or an individual more desirable to become an employee. Some of the things are knowledge-based. In other words, things that we teach you here. Some of them are skill-based that you've had experience in doing. And the hardest one are the attitude-based ones. The things like punctuality and the things like ability to get along with others. And that's part of the hardest part as a manager, to be able to identify in a prospective employee. So here's an example of some core competencies of a respiratory therapist. This is really administering a therapeutic modality or demonstrating a procedure, performing cardiopulmonary assessment. Those are all tasks that you're able to do. It's a little bit dated. Most of the time, that first one is where you're going to probably pick up on any kind of employment. As I've said probably 1,001 times, it's an 8-week job interview. I think the vast majority of people who graduate this program and get a job work at or rotated through that institution at some point along the line. It's probably the most common place it ends up happening. Resume, single page. If you want to send me your resume or send me a resume, I'll critique it and get back to you with it. The shorter the better, 1 page. Spell check it, and that includes the cover letter. But you should emphasize those core competencies. What do you bring to the table compared to everybody else? They're going to assume that you don't have a whole lot of experience, but what experience you have as a patient care tech, there's skills that are transferable to a respiratory therapist working in a department, as far as patient interaction skills. If you have any additional training in some other area, include that also. Experience, I always, if you've had experience with, say, APRV, I would include that, because that's not something that everybody has been exposed to. If you have experience in high-frequency ventilation, include that. Those kinds of things. Okay. Here's an interview. I love this interview question. You're driving along in your car on a wild, stormy night and it's raining heavily. You pass by a bus stop and you see 3 people waiting at the bus, waiting for a bus. An old lady who looks like she's about to die. An old friend who once saved your life. The perfect partner you've been dreaming about. Which one do you choose to offer a ride to, knowing you can only fit 1 passenger in your car? Go ahead.
I know this too.
What's that?
I know the.
Oh, you know the answer. Don't say anything then. What do you think? Well, here's what the winner answered. I would give the keys to my old friend to drive the old lady to the hospital, and I would stay behind and wait for the bus with the partner of my dreams. Out of the box, right? It's not something that the majority of people would end up finding. I love that question. How many people have been on an interview recently? A couple of you, okay. I used to interview every 5 years, whether I was looking for a job or not. Just so when the job came that I really wanted, I wasn't out of touch. There's a lot to it. Know the system that you're working with. If you're going to Beaumont, that's a totally different beast than the St. John system, which is totally different than Crichton, who is now part of the St. John Assumption Health System. If you know who's going to be interviewing you, it's good to have a little bit of background on who that individual is, and don't be afraid to ask me. I know pretty much every manager in every hospital locally. Even if we don't rotate through there, I can tell you who's in charge there. More and more we're seeing panel interviewing, where it's not only the manager, but it's some of the respiratory therapists on staff, which is rather interesting when you walk in. When I walked in for my interview here, there was a panel of, I think, 7 people. That's always fun. Rehearse facial expressions, body mechanics. I've had people on an interview, women who were just sitting there playing with their hair. It's like, nervous habits, but it's stuff that you have to learn how to get around. 60-second personal statement. Tell me about yourself in 60 seconds. How would you describe yourself? Practice questions. Have some questions that you would ask back. You know. And then we talked about the resume. Conservative dress. Yeah. You know how not to dress, let's put it that way.
I used to interview people at Walmart, and I had a girl show up and stuff.
I've had women wear tops that were probably not appropriate.
The more moves you show, the better chance you have to get that job.
Not necessarily. So, know where you're going, allow some extra time, plot it out. The last thing you want to do is be late for an interview. One tip I used to always use is go to the restroom, wash your hands so they're not sweaty. They're cold. A little bit of a cooler hand to shake hands with is better than a sweaty, warm hand. Does that make sense?
Yeah.
Be polite. Don't be confident. Or be confident, but don't be cocky. Focus on your strengths. Watch for nonverbals. Listen. It's an important skill set that a lot of people don't have. Don't be too familiar. Yeah. I had one interview where I don't think the person ever looked at me the entire time. One of the things I used to do when I used to freak people out, I would pull out a list of blood gases and say, interpret number 3 for me. And I remember years later somebody saying, I just about. Don't appear desperate. It's okay to ask about money. They know that you're going to want to know what you're going to get paid in the process. They can't skin you and they can't eat you alive, so relax. Some common interview questions that you might end up seeing. What are your strengths and weaknesses? And we have any weakness? Of course you do. We all do. Why did you leave your other job? It's pretty obvious. You're going from you're entering a new field, so a lot of these don't necessarily make I have a friend who asked that every interview. If you were an animal, what animal would you be?
I was asked before at an interview, if you could be any car, what car would you be? It's very strange.
Why do you think that is?
Maybe a personality.
Personality, yeah. And it's a question that makes you think out of the box. I'd be a giraffe. Hyena? Like I said, it says a lot. This is becoming more and more common of a situation. It's called behavioral interviewing, and it's telling about how you reacted to something in the past. So tell me about a time that you had a conflict with a friend and how did you resolve it? Tell me about a time that you encountered a patient who needed some intervention. What happened? So you got a problem, what action you did to try and address that, and what was the outcome. It shows your ability to problem solve. Of all the things that managers want, they want somebody who has critical thinking skills, who's able to work through a problem. They don't want to have to hold your hand for the next 12 years or whatever. Okay, so that's an important skill set, and that's what we're seeing. Probably, I would say, more and more those kinds of questions. You agree? References, always ask who you're going to put down for a reference. For the most part, I have always said I would use me as a reference, but ask first. When you're done, I always say journalize it, write it down, think about it, and then before you go for your next, go back and look at your notes. What did you do right? What did you do wrong? So that you're better. That's why I'd interviewed every five years, so I just didn't lose that skill of interviewing. And a follow-up letter is always a good idea too. Say thanks for an email. Thanks for taking time to interview me. I really would be excited to get the job. So, comparing it to a date, it is true that first impression is huge. Often first impressions are wrong, but first impression does set the tone in a lot of cases. Yeah. How true is that? That must have hurt. Okay, let's talk about rehab. And there will be a question on the test, I think, on rehab.
So nothing on...
Nothing on management, but it's something that you should be aware of. This is the ATS and European Respiratory Society's joint statement on what pulmonary rehab is. Multidisciplinary, comprehensive. It's designed to reduce symptoms, optimize functional status, increase participation, reduce healthcare costs. And we know that anyone who has COPD is the most common person that is in the rehab program. But really, that's one of the things that, if you look at the gold standards, although they did change them a little bit, but anything from stage 2 onward, moderate COPD, pulmonary rehab is part of that program. Okay. You guys, as bedside caregivers, are sometimes the best people to recommend pulmonary rehab. You got a patient who's got some pretty profound COPD, and they're not in a rehab or have not ever been in a rehab program. That's a perfect person to make that recommendation to the pulmonary rehab area. We know about obstructive diseases, both types of COPD. I've seen severe asthmatics benefit tremendously from it. Yeah, as well as restrictive diseases have benefit from it also. Ankylosing spondylitis. Love it. It just sounds like a neat disease. It's basically where you end up having joint issues and the thoracic cage can't move effectively. Lung cancer, you don't usually see that much because by the time they're diagnosed, it's usually pretty severe. Pulmonary hypertension, I have seen. Lung transplantation patients. Don't see a lot of peds rehab, but their potential is out there. And this is why we end up doing it, because the spiraling down of the disease, it just worsens itself as time goes on. What is involved is primarily the exercise that goes on. So it's graded exercise that the patient is doing with or without oxygen, with supervision by a respiratory therapist, typically. But there's also a patient ed component. So we teach them about their disease. We teach them about pharmacology, the medications they're taking, and the delivery devices that they're utilizing. Teaching them about oxygen. There's so many myths that people have. I'll get addicted to oxygen. I remember a friend of mine was saying, I was driving, this car pulled up next to me, and this guy's got a nasal cannula on. I said, yeah. You shouldn't be driving. He said, do you wear glasses? Yeah. Well, why do you wear glasses? Well, I can't see without them. Oh, okay. Well, he can't do things without oxygen. But just the whatever. Often we'll have an OT or a PT, have somebody from dietary come in, have somebody from pharmacy come in. So it is truly multidisciplinary. You guys all know what the 6-minute walk test is, right? Okay. And we know about inspiratory muscle training. Evaluation of dyspnea can be done with the Borg scale or the visual analog scale. Visual analog scale is a little bit better, although the modified Borg is what is typically ended up utilizing. And this is the visual analog. The scale is 0 to 3. Where do you fall at this point in time? So while they're exercising, they can say, you know, I'm at a 2. This is the modified Borg. To me, some of these steps between a 5 and a 6 and a 6 and a 7, I don't see a whole lot of difference in there. But severe, very severe, very, very severe, maximal. But that's the Borg scale. This is interesting, and I always threaten that one day I'm going to do a lecture just on dyspnea, because I think it's fascinating. These are some examples of how different disease states describe the shortness of breath that they're exhibiting or that they're feeling. I cannot get enough air. I feel out of breath. My chest feels tight. Different ways of expressing the same thing in the sense that dyspnea, but it's because of the different pathologies that are present. That was interesting. Something that we need to keep in mind also, sexuality. Sexuality is your feeling that you are able to be intimate with somebody else. And if you're short of breath, that process can be difficult, which only makes the disease process more frustrating. And if you can't breathe, it's kind of hard to be intimate with another individual. How do I say this nicely?
Yeah.
Drink provokes the desire, but it takes away the performance. Our Macbeth. And I think we'll stop there.